so please prepare for team 3 for the PPT. Maybe you can just go to the next slide to make sure that it's the right one. No?
How do you watch
The other one should be titled like. There is a title. There is a date on it, like 20.
Set a timer for 3 minutes. Were judges ready for the week? Okay. Are you ready for team 3?
Ready.
And then you can start now.
The slide.
Yep.
Okay, hello everyone. Let us present our study. Next. Okay, imagine this is Andy, okay? He just enrolled in a university in Banten. He born with HIV, yeah, but his peers doesn't know it yet. At the stage where peer acceptance are defined his worth, he think a lot about what his peers know about this disease and how they feel about people like him and how they get trusted information about HIV. Next. Banten carries 76% of Indonesian HIV burden alongside 11 other provinces. So this may make we ask about what do first year non-health track student in Banten already know, believe, and where do they get HIV information from. And this baseline study before any campus exposure shapes them. We used the study design cross-sectional survey from Hafiz 2020 with 134 first-year undergraduate students aged around 17 to 20. We do data collection about information search, HIV knowledge, HIV attitude, and then we do statistical analysis. And the study outcome will identify knowledge attitude gaps to inform the need assessment pace for the task force of prevention and handling of sexual violence.
All right, and the result that we get next, we see that information sources, the student actually trusts internet the most, access internet the most, even though only 6% use it, trust it the most. And then they trust healthcare worker the most, but only 6% turn to them for their primary information. Next. Generally, we see that knowledge and attitude is good in this population with a significant moderate positive correlation between knowledge and attitude. But when we look at the attitude subdomains, we can see that stigma is the lowest there. Which means that they have unfavorable attitude toward the unfavorable. They have stigma toward people living with HIV/AIDS. Next. We understand that this study is have a small sample size and convenient sampling. There might be selection by social desirability bias, but we can still use these findings to prioritize needs assessment before designing any HIV program by the task force. And we can do the next step is to conduct confirmatory study with a more robust design.
Okay, time's up. Thank you for the presentation from team 3. And please set a timer for 6 minutes for the debate session. Are you ready for the debate session? Okay, and then you can start now.
Okay, thank you for your nice presentation. And maybe the first thing I would like to comment and also need clarification is about your title. You said your title is the knowledge among university students, right? But you did this study in one university only, so I don't think it's representative enough to describe the knowledge among university students, because Eastern and Western of Indonesia might have different perspective on this too.
Okay, thank you. Since our primary object was to establish the baseline data, that's why the next step is to have a larger study that will directly involve many university or multi-center.
And to clarify, the title is university students. So we're talking about students in plural, not the university in plural. So we're being honest there that this is just one university, but there are many students inside the university.
Okay, yeah, among university students, but I also think that you need to specify like which university. I think it's better for us to not like generalize the results, right? And then you're talking about the baseline too. This is the baseline data for your further study or other studies, right? But I believe that to have a baseline data, we need a variation. But you did also mention in your presentation that this sampling might be biased, might be based on convenience. So how did you validate your findings as a baseline data?
Yeah, again, so the particular context for this study is because Task Force for Sexual Violence, for the Prevention and Handling of Sexual Violence, it's a very new, regulation by Permendikbud. They're just being, the regulation itself was in 2021, and the implementation is not yet there in even some universities. So this is really a baseline data because it's not functioning yet, and we want to know like what's there without any intervention in one particular university, because if we're trying to look at other universities, they may not even have it yet. So we want to like be really focused on this study, and we know that that's the limitation to begin with.
Okay. And another question. I would like to focus on the strongest statement in your conclusion. Knowledge-based approach alone are insufficient. Which analysis in your study directly test that claim?
Yeah, definitely. So if you look at the Spearman's rho correlation, it generates the result of rho 0.35, which means that knowledge alone only accounts for 12% of what makes the the positive attitude in students. That means like 12% is like 1 out of 10. That means like there are 9 other factors that needs to be accounted for, which we did, like the design of this study was not robust enough to account for the other confounding, which calls the need for the next more robust study.
Okay, I just noticed about the statistical analysis about the Spearman and the fix. Why should the research place the confidence in the significant Spearman result than in the non-significant Fisher exact test result? Yes, both of them is really different.
Yeah, so the primary outcome of this analysis is the primary statistical analysis that we use is the Spearman's rho. It's analyzing a continuous data. So from the knowledge and attitude questionnaire, we generate like the sum, the mean. We use that continuous data to conduct Spearman's rho, and the sample size is adequately powered for that analysis. So the result is valid for that first one, but when we categorize, it's the sample is not well powered to do that analysis, so the result is not significant.
Okay, if your conclusion is simply because the same data are analyzed differently, right? Doesn't that suggest the evidence for the relationship is less robust than the conclusion implies? How about that?
Can you clarify? Sorry.
Yes, I like about the analysis different and the Spearman and when you categorize it as is totally not significant. But if you use a numeric analysis, it's significant. If you add the date or something like that, and you categorize how about the result will be robust or?
Yeah. Okay. So again, since I mentioned earlier that the primary outcome itself is we're analyzing the continuous data, and so we count the sample size for that primary analysis, and when we run the secondary analysis, when we like categorize them, it's just not adequately powered, and hence the need for further study with a larger, preferably total sampling.
Okay, moving on from the statistical sides. So I wonder, like, you also include entire retroviral therapy in your questionnaires, right? And this also recruit non-health track university students. So I wonder why this knowledge is important for them, like, yeah.
1 minute for you.
Yeah, sure. So the reason that we chose this particular questionnaire from Hassan 2020 was that it was deployed in high school students, like end of year high school students in the vocational health population. But then we devised it in university students who just got accepted and have not yet had any exposure in the university. So we thought at the same like age range and knowledge exposure, they're quite the same. And so we acknowledge that that particular question might not be, a best fit for this particular population, and it's not validated yet in this population. Hence the call for the validated questionnaire in the next study.
That's it? Okay, that's for the first round, and then you can see on the screen for the current score. Yes, 11 for team 3 and 7 for team 38. And please set a timer for 1 minute for brief session. Okay, and then maybe you can go to the slide for team 38, who will then check. That's the correct slide or not. Can you check please the slide? Is this the correct one? Okay, go back to the master slide. Okay, go back to the slide. And set a timer for 3 minutes. For team 38, are you ready? Timer set? And then you can start now.
Okay, good morning, everyone. I hope everyone has a good start in the morning. My name is Meisha, and together with my partner, Haddad, we would like to share our findings on the epidemiology of high-risk human papillomavirus infection and its associated risk factors in Lombok, Indonesia. Next. So recently, our Indonesia Ministry of Health has launched a program, a national program called the HR, or High Risk HPV DNA Screening Program across Indonesia. But little do we know whether this policy is actually targeted or efficiently conducted in the real world situation. Because why? Because previously reported studies also have shown that risk factor for high risk infection of HPV is also based on the geographical settings. So next. In this study, we would like to find out whether or not the epidemiology in Lombok or the characteristic of participants in Lombok similar with the previous studies, so that we can conform to the local policy to adjust the policy if it is required. So in this case, we did a community-based screening, which involved midwife and which involved trained midwife to do the cervical sample, cervical swab collection, and also we did genotyping by the available manufacturer kit.
Okay, next I will briefly explain statistical analysis and the findings about this study. We ended up in 414 participants and 78 variables, and the analysis start from the pre-processing data until we move to mixed effects model. Next, we found that 24 positive cases, mostly in central Lombok, and the risk factors, air pollution exposure, and irregular menstrual cycle were significant as a protective factors, and the prior knowledge model variable were not significant. Next. Okay, for the conclusion, our study presents that environmental factors, in this case, air pollution exposure, increase the outreach of the HRSPP, and the woman with irregular menstrual cycle decrease the outreach of HRSPP. And our recommendation of further analysis are needed to explain potential confounding variables that may affect the observed relationship. Thank you.
Okay, thank you for the presentation from team 38. And then please set the timer for 6 minutes for the presentation. Okay, are you ready?
Okay, so you we want to address the study design first. Firstly, your design does not include two of the most consistently identified risk factor in HPV infection globally and locally, which is number of sex partners and then contraceptive use. They're not in your table and presumably not in your model. So how did you address? And you mentioned that further studies needed for these confounders. But how confident are you that your significant association aren't?
Okay, I would like to confirm that we did include number of sex partners and also contraception use in this case, but we did not show it in our presentation and also our poster because it doesn't show significancy when we test as a correlation. But we did also involve this as the variables or the parameters for sexual behavior.
The next is with 23 of 24 HIV positive case coming from the Central Lombok, how can you be sure to identify the risk factor are not reflecting regional clustering?
Okay, yeah, we need to, I believe that the participant recruitment across Lombok has been randomized also, and then it doesn't meaning that we choose like specific hotspot in the Central Lombok so that it's also positive, the positivity is high. So I believe that by choosing the population randomly also, it has been representative.
Okay, you mentioned that you're using random intercepts for the sampling, right? But then it accounts for the clustering in standardization error, but it doesn't really account for cluster level risk factors that might differ for those populations. How do you account for that?
So actually, we did also include the area of recruitment as a random effects in our modeling. So it has been accounted in the statistical side, yeah.
Talking about the air pollution, how was the air pollution exposure assessed and what evidence support that validity to measure this in individual level?
Yeah, we need to acknowledge that we did not quantify the air pollutants directly, but we did qualitative questionnaire that is ordinal. So the participants were asked whether or not they live nearby garbage burning site or the hotspot of garbage burning, or living nearby the house or the residence area where transportation is quite high, like 1 to 2 kilometers, 500, or yeah, something like that.
Yeah. So your multivariable model, the rule of thumb is for logistic regression is 10 to 15 events per predictor, but you're with only 24 cases, then it's at a high risk of overfitting. Like how do you justify that this model is not overfitting?
Okay, it's not overfitting. We believe that our model of the multivariable model is just an optimal model, because if we use likelihood ratio test used for compare about the model and the model test to include the variables into the model.
Okay, but as you can see in your own table, the OR for air pollution is 5.11, but the confidence interval is really, really wide. So it looks like overfitting. How many variables actually entered your final multivariable model? And did you do any internal validation for that?
Okay, we believe that we use a lot of model, and then the result just the three model that's significant, and the recruitment area just be a random effect, and then both of them air pollution and the irregular menstrual cycle be a fixed effect that associated with HPP.
And then could the association simply be driven by geographic clustering, since only 23 of 24 cases come from Central Lombok?
Okay, in this case, we just can claim that it is association with the not just clustering, because like we have included the area of recruitment as our random effects, right? And we also have acknowledge that each area might have their characteristic of, like, for example, air pollution criteria. So we cannot we cannot justify that whether or not this is directly correlated to their area of recruitment.
Got it. And then your inclusion criteria is actually women aged 30 to 69, while we know that HPV peak for women less than 25-year-old. And so this is like you're leaving out most of the most vulnerable population. How does this eligibility affect your prevalence estimate, and is it comparable to other Indonesian studies?
Yeah. First of all, I would like to confirm that our eligibility study is not only specific to women aged 30 to 69, but if you see in the previous point, we have also include women who have married or sexually active. So this criteria, this eligibility itself has included women underage, less than 30 years old, but have been married. Yeah.
Okay, and that's it. Hands up. Maybe we can wait for 10 seconds to see the final score. All right, that's the final score for this match, and we have the winner here with team 3 with the score 15, and for team 38 with the score 14. Congratulations for all of you. Very great discussion or debate, and please 1 minute maybe for judges giving the feedback.
Thank you. So I can feel like this morning session is getting more intense than yesterday. And I would like to say that it's already good debate because everyone already know how to attack and defense. So I think, yeah, it's really, really, I can enjoy the discussion as well. So yeah, good luck and yeah, thank you.
Thank you. I was rooting for this team, actually. But I guess time is the actual judge, yeah. The reason is very important because our group also published this HPV prevalence, and I would like to see your poster because the important is about the policy. Because we always want to push the HPV screening as the first line of prevention. But until today, it's not really happening yet. So I would like to look at your data closely, hopefully. Yeah, after this, maybe we can discuss. Thank you. Good job, everybody.
Thank you. Thank you so much. And then we can go back to this.
Ini kan sudah ala ketua KDKI-nya, nanti sudah tereliminasi dari namanya.
Enggak, bukan gitu. Ini di sini kan masih belum ada tanda salamnya. Nah, tanda salam dulu. Mana ini? Kok nggak ada sih? Bukan di sini. Oh ya? Belum ada masih.
Enggak, dia jangan lagi.
Tuh. Iya lah, ke distrik tadi serta. Pas juga di semester 1 ya. Lagi mulainya.
Iya, depan. Jangan cuma satu depan. Ini tadi udah datang. 0084. Kan dia benar. Yang lulus. Dia bisa terima. Ada filenya.
ini juga kan pakai ART ya sekarang ya. Betul. Udah mulai juga gitu. Ya tapi nggak terlalu banyak sih paling banyak berselancar kalau hari itu listriknya sampai 3 kombinasi obat yang berbeda. Pakai kombinasi ya ada yang mengatakan seperti tesnya nomor testingnya terus kayak gitu dan terapi sama lagu begini itu kan beda-beda. Mekanisme jadi itu bisa memperbaiki hal ini. Nah sekarang yang di Barat itu kalau misalnya mungkin ada yang paling tidak 2 kombinasi bisa menambah yang berbeda ya. Karena kalau cuma satu lebih gampang. Tapi kalau misalnya ini aja yang di kopi itu ini aja.
Bisa langsung ke pingin. Oh nggak bisa ya? Oh oke.
Atau mungkin karena Mac kali ya. Sorry. Saya bisa Pak. Ini bisa ya. Tapi ini saya bisa Pak.
Harus di
Awan.
Iya, lawan kalian lagi tunggu di sawah depan. Belum final deh, belum ketemu. Sebenarnya Ibu Sumeru masih.
Yang sekarang ini lebih lama ya 30 menit.
Normal tahun 30 menit.
Kemarin juga 30 menit.
Itu
cuma 1 belasan. Nggak memberat itu ya kemarin.
Cuma standar sesinya 18 menit sih Pak.
Iya kemarin kayaknya saya lihatnya 18, kok ini jadi 30 menit apa ditambah atau gimana?
30 menit untuk mereka perpindahan ruang.
Oh, sama perpindahan ruangnya. Oke.
In case ada extra time kayak draw atau
Ya. Oh ya tahu tahu tahu. Dulu saya juga biasa lupa. Ex-bioteknologi gitu. Jadi iya. Saya bioteknologi itu masuk 2015. Tapi cuma setahun kemudian malah kebiasaan di Hannover pindah ke Bochum karena sekolah sana kebetulan dapat promosi full profesor di Bochum. Iya. Terus balik-balik udah jadi dia. Iya. Jadi saya tahu boleh sih sebenarnya. Cuman pada waktu itu bilang sama malah di dokter saya nggak maksudnya suruh pulang dulu kita bilang nggak boleh repot deh nanti aja kalau udah setahun 2 tahun baru keluar lagi. Iya. Tapi 2 tahun ini agak menyesal sekarang. Saya kebetulan lagi ngerjain di HIV baru mau Pak. Nah, karena ya itu masih menanti walaupun sebenarnya udah mulai jenuh ya di aturannya semua udah di-explore kan. Sebenarnya
lain sebenarnya. Paling dari grup Pak, dari itu kan saya lagi.
Okay, please prepare for team 12 and team 84. Please get your seat for the right side for team 84 and left side for team 12. So here, 84 right side. This one for the number. Maybe when we're waiting, you can check for the PPT from both of them. That's the correct one or not. Tim Haryanto and Tommy, is this the correct one? Okay, go back to the next. For team 12. Is this the correct one? Yeah. Okay, go back to the slide. And it just this number until number. Okay. Automatic detail, okay. Number. Okay. Number. You wanna go the first or you whatever first? 84 will be the first, so please prepare for the next slide. And while we waiting for the team result, I would like to remember your team or the role of this meet. So we have a 2 rounds, and the first round you will be team defender and you will be team attacker. So you need to present your research, and then after that 6 minutes to do the debate session. And then the debate session, attacker just have 30 seconds to attack the team defender and 1 minute to defend your idea. And after that we have 1 minute to do the break session. And during the break session, please do not do the conversation both of you. Yes, you can have a conversation between your teammates. And after that, we're gonna go to the next round. The second round will be team defender and the team defender. Okay? Are you ready?
Yes.
Okay, set a timer for 3 minutes. You can start the presentation now.
Good morning, ladies and gentlemen. My name is Haryanto and my colleague Romi. Today we will present the emergence of colistin resistance and heteroresistance in Acinato-Baterbamani, a sequential time kill and molecular characterization study. Next slide. So this antibiotic, colistin and polymyxin B, is the polymyxin class antibiotic. The mechanism is binding to lipid A of lipopolysaccharide and causing cell lysis. This antibiotic used as a last resort drug to overcome infection caused by multi-drug resistant gram-negative bacteria. But since 2000s, the first clinical isolate of colistin resistant albumani was reported, and imagine that we will pass the era before first antibiotic was found. Next. So the objective of our studies are to evaluate the bactericidal activity of colistin and polymyxin B and their roles in the emergence of resistance, including heteroresistant and adaptive resistance. And the second one, to characterize genetic alteration associated with this resistance. We used 2 clinical isolates, the susceptible and resistant Acinato-Baterbamani, isolated from the same patient before and after the colistin treatment. And when we determine the difference between these 2 strains by DNA sequencing, and then we perform the sequential time kill. Next. So we found that between the susceptible and the resistant one, there has a PMRB gene mutation, 13 nucleotide duplication, leading to the LPS modification and leading to the high-level colistin resistance. Next slide. And for the in vitro study, we found that a susceptible one could develop to step-by-step resistance under colistin pressure, and the polymyxin B has a low adaptation. And in the resistance strain, it could regrow until 16 times MIC, showing the high level resistance, but it has low adaptation in polymyxin B. And we found also there is an overexpression in FLXC gene that cause the loss of LPS, and we predict this is the mechanism of the resistance. And also we found that there is a subpopulation based on the population analysis profile in this resistance strain before their contact with antibiotics, showing there is a subpopulation that has a high level resistance compared to other strain based on the MIC results. Next. So, ebomani adapts rapidly under colistin selective pressure in vitro, but minimal adaptation to polymyxin B. And this high-level colistin resistance is a dual-step process from LPS modification to the loss of lipopolysaccharide and could lead to high polymyxin resistance. What the implication of this study? The sequential time kill over a simple approach to discriminate different PD model structure to describe the emergence of resistance. And based on this model, we could predict and prevent the resistance in the next study. Thank you so much.
Thank you for your presentation from team 84. And this is the time of our 6 minutes for the session. Okay, are you ready? Where's the microphone? Okay, for the session, we can start right now.
Okay, so in your study, you measure the RNA expression. We already know that RNA expression, RT-qPCR, it's very determined by the environment. Could you please state it? How can you exclude that confounding variables from the RNA expression?
Okay, so we do the single sequencing, we do the RT-qPCR. Thank you for this question. And we already established the lab to do this, and there is we do in the sterile area, and there is no confounding because we use the specific kit to the RNA isolation. And then why we do RT-qPCR because this is a specific gene that we want to know related to the colistin resistance. And actually, I would like to explain also the main message of the study is to challenge the bacterial towards the selective concentration of antibiotic. And then we will know if there is an adaptive resistance or not. And this characterization gene expression want to support this time kill result.
Yeah, we do understand, but could you please state it, the exact temperature, the exact moisture, the exact of other parameters of environment? Because we have to ensure that every parameter is right, because the RNA expression is very evaluated by the environment.
Yeah, we already optimized the method. We already have the temperature also established by the lab, and we only follow the protocol that already established.
Okay, so in your study also talk about the gene expressions. Yes. We all know that gene is, at some point, they have a gene links, but you only focus on the PMR genes. Yeah, I think that in terms of if you want to find the gene expression, you also have to think about the gene link. And in this study, you only limit in specific genes.
Thank you for this concern. The mechanism of resistance towards the colisins already established. There is a PMRBC mutation or LPXAC mutation. So why we focus on these genes? Because this is clinical isolate, and the patient got colistin treatment. So why we target this gene? Because this gene is related to colistin resistance. So we don't want to know the other mechanism because we want to develop the model as the first objective of the study, and this gene expression sequencing and the expression genes want to support this data. So why we all only focus on this gene? Because we already know the doctor give the colistin treatment to this patient.
Yeah, but we cannot really say that it's only one gene. In terms of human, it's very, especially also even though it's like a bacteria, it still have a link gene that could responsible. Perhaps in the literature mentioned that it's only one gene that responsible for type of mutation. But
yeah, but
yeah,
Yeah, but whole genome sequencing for the Acinetobacter is already established, and the mechanism of resistance already established. This gene results only confirms our results. So why we should do whole genome sequencing if the mechanism of resistance already established and the main study is only to perform the PD model? Why we should do the whole genome sequencing that will be expensive? This is so practically actually.
Is it the same strain? Could you say that? Is it the same strain that already in the whole genome in the previous study compared to your current study? It
No,
should be different.
No, you mean the mechanism of resistance?
Yeah, I mean,
mechanism of resistance
different
already.
strain could, different strain could give the different type of gene link. Especially you mentioned about the mutation and so on.
Can I say? Yeah, the different. Actually, this is the first clinical isolates in our lab. So, but since 2000s, there is already established the whole genome sequencing, and all the mechanism resistance is already reached since 2000s, since the first clinical isolate was found, and that's why they already have the meta-analysis review about the mechanism and resistance, and we, based on this study, we just focus on the resistant mechanisms towards the colistins. That's why.
Okay, as you said before, the genome was established from 2000, right? But in your study, you only, as we read in your poster, we only find that you only have 2 samples, right? But isn't it a low quantity for data? So I think it can be there's this research maybe not not too.
It's not really important.
No, it's really important because the patient is only 2.
Okay, so actually this result based on first we should we should explain that this is the start of this study is beginning from the case report, and the clinician want to know why it cannot has treat by colistin that they already give, and then they we study the mechanism of resistance based on the cases that they already get the colistin treatment, and this is a big study, actually important study, because this is the first clinical isolate that was reported in our hospital. So if this is not a comprehensive study that to want to know how the clinicals as the same mechanism or not, no, this is not the main purpose. And then as I want to explain, we want to perform the sequential time kill. Sequential time kill didn't need to use whole different strain or different phenotype. Thanks.
Okay, that's it for the first round. And set the time for 1 minute for the break session. And set. 3 minutes. Yes. Are you ready?
Can we check the
Yes, you can check it first.
person?
Correct one?
Yes.
Okay, go back to the first slide and then we can start right now.
Okay, thank you. My name is Juniza. I'm a partner in Zainur. We want to present you about potential compounds of Pedireftidine as anti-cancer agents against to prostate cancer through comprehensive in silico studies. Pedireftidine, maybe you can know as kentutan leaves. Next. it's about 400,000 people die of prostate cancer in 2022. But in Indonesia, we also know that pivotida as the ethnomedicine in Sia culture as the anti-inflammation, and there's in vitro studies to prostate cancer using the cell line PC3 and GU145. So we want to know the specific compounds of that, which one is have the anti-cancer remain unclear. So we aim to investigate the anti-cancer compounds of pivotida against the prostate cancer through in silico next. So we have 6 machine learning for pivotida, and we train the all of the components from the database, and we use the pass and admin to eliminate the non-active compound. So we will have the only active compound that we will do the docking with the PARP1 protein.
Next slide. So yeah, based on that, we found that 6 models have different characterizations that, but the higher accuracy compared to other models is SVM models. We reached to 90%. We already tuned it, and based on that, the best model, we try to apply it to our new data set, 59 compounds, and we found that 54 compounds out of 59 compounds, which is 90%, have anti-cancer properties. Next. Yeah, and we also try to filter that 54 compounds into 25 compounds and using a PES online, and which is have a related apoptotic activity, and we also try to filter it using 6 compounds using a Lipinski rules of 5, and next. Yeah, and based on that 6 compounds, we found that the lowest, it should be the lower binding affinity is Licarin A compared to any other compounds, and this shows that the Licarin A don't have a great, compared to enzalutamide, which is our positive control, they don't really have a far difference. And we also try to see which type of residues or amino acid that dock into the Licarin A, and as you can see, we already established that it could be mimic the conformations of the PARP1 in terms of DNA repair to inhibit that DNA repair resulting in the apoptotic activity. Next. Yeah, next. So based on that, we found that 6 out of 59 compounds have anti-cancer properties. Thank you.
Okay, thank you for the presentation from Ms. Paul. And please set a timer for 6 minutes for the session. Are you ready? Ready?
Ready?
Ready. Okay. And then you can start right now.
Okay, thank you for the interesting presentation. I would like to ask about your title, because in your title, science that the comprehensive in silico study, right? But in this result, I only found only molecular docking study. Do you think this is not an overclaim from your title? Thank you.
Okay, thank you. So what we meant by comprehensive in silico study, we have filtered every compound. We don't do blind docking. So as you see that, we have filtered using the machine learning at first and filter it with the current known PAS online, which is the prediction in general. And other than that, we try to filter it again using bioavailability using Lipinski rules of 5. So we have a lot of filtering at first, and after that, we're very specific on type of potential compounds. By that, we can assume that it's a comprehensive in silico study.
Yeah, but in my mind, what you did is only 20 or 50% of the comprehensive in silico study, because comprehensive in silico study meaning that you do the ADMET prediction also, network pharmacology, QSER, etc. But I don't. Thank you.
Yeah, in terms of QACR, I don't think we really need that type of methods in there. But in terms of network pharmacology, we do understand that network pharmacology at some molecular, in silico study is very important. But in our study, because we already established the FDA-approved drugs, already established about the PARP1 specific target, so we don't really think that it's necessarily right now to do the network pharmacology. And that we try to replace it with the PAS online prediction, which is quite similar actually with the network pharmacology.
But thank you. But I think you should only specific on the molecular docking study in your title. Sorry. And the next question: why you build the ML model for prostate cancer with general mechanism at the first, but when you validate the results, you drive the mechanism specific to PARP1 inhibitor. This is not correlate actually. Thank you.
Yeah, so the justification of that is first, the machine learning model is determined and built by the compounds that have anti-cancer of prostate cancer. And we all, based on the literature review, that prostate cancer is, for the FDA approved drug, is usually used the targeted protein, which is PARP1. And we think that it should be a correlation based on that. And before that, we also think that using the other prediction tools, which is the PASS online, we only focus on apoptotic. And PARP1 is also a protein that focus on that have correlation with apoptotic mechanism.
Okay, to continue, I was wondering why your study uses enzalutamide for the control compound when there are other PARP1 controls that are very widely known and very widely used, that is olaparib, niraparib, and ruciparib, and all has better binding site on each NADP. Why would choose to use enzalutamide rather than the widely approved one?
Yeah, in terms of the native ligand, we use enzalutamide because this type of protein that crystallographed before by the previous literature is coming from the enzalutamide and PARP1 docking. So we cannot replace it to another ligand, which is you can say olaparib and so on, because there will be some different. So we don't want to make it different. So we want to focus on PARP1 and using enzalutamide as our positive control.
Yeah, but you mentioned in the model, in the valid model, you use the mechanism as PARP1 inhibitor. But enzalutamide is an androgen receptor inhibitor, not PARP1 inhibitor. This is different. Thank you.
Yeah, we do understand at some literature it's different, but we use that our literature that justify that the PARP1 also inhibit by the enzalutamide positive control. So we fill that gap.
So you admit this is the gap?
No, I mean, based on, you mentioned that previously, right now, that enzalutamide use the androgen receptor, right? But right now, based on our database, which is, as you can search it, this...
Yeah, we already searched it, actually.
Yeah, the enzalutamide is already docked into the PARP1, and it's already proved by FDA.
Okay, and also how you confirm that the docking method that you use could reproduce the native ligand, since we didn't find the redocking result. Redocking result.
Sorry?
We didn't find the RMSD, redocking, because you only your results is directly to the docking result, but you didn't perform the validate the RMSD to Armstrong.
Yeah, we actually have that in what type of protein and what type of amino acid, but we cannot really put it in our poster. So yeah, it's very limited space.
Okay, I want to ask about the 6 algorithm that you use, and why do you specifically choose SPM with only 15 test sample?
It's not 15 test sample.
No.
I think you misunderstood. We have different. Sorry, we have different data set to develop our machine learning.
Okay. Yeah. Okay.
Okay. Thank you for both of them. And just wait for 10 seconds for the final score. Okay, that's the final score for this match. So we have team 12 with the score 12, and the winner for this match is team 84 with the score 14. Okay, please set the timer for 1 minute for feedback session from our judges here.
Yeah, it's quite interesting match. Maybe just a couple of feedback for the team here, our pharmacist. I think it is very. I just realized that I think it's also very important. You probably stated in the very beginning that you actually use the clinical isolate, actually from real sample from the hospital. I mean, that's actually a strong point. That should actually really stress it in the beginning, because to get this kind of sample, it's not easy, and it has actually some clinical relevance data. So that should be, something that you can consider when you present it, and because it gives you some uniqueness, right? Not instead of just a random screening, right? And for this team, again, I'm a cancer person. I would like your team to win, But when you guys actually debating about the PARP inhibitors, of course, there are a couple of mechanisms, but I just want to make sure you guys understand, and probably have or done your homework. The PARP inhibitor in prostate cancer actually is not the target. It's not a target itself. It's not a sole target. For instance, in a prostate cancer, yes, you can target PARP, but that's actually in context of BRCA mutations. So not all prostate cancer you can actually treat with the PARP inhibitors. Either they have problem with androgen receptor with enzalutamide that you mentioned, or these patients have actually germline or somatic mutations in the BRCA1 or BRCA2, mainly BRCA2 mutations. I mean, for the pharmacist, you should probably understand this with precision medicine, but that's actually more enrich your understanding, because we don't want people to get the wrong idea. Okay, PARP inhibitor is the driver for prostate cancer, because generally you want to target a protein that's actually a driver, not a passenger, right? So that's why if you notice, the PARP inhibitors always with something in different backgrounds. For example, in a BRCA mutation background, or in conjunction with the anti-androgen receptor, not targeting itself. Hopefully, it will enrich your studies. But again, congratulations! It's very nice, everybody. Thank you.
Yang apa yang winner kan? Yang 008. Yang ini 84 kan? 030 panggilnya. Udah dia masih guningin Pak. Oh iya. Lawannya juga lagi kita lihat. Oh, langsung ya? Iya, habis ini tanding lagi. Siap-siap. Oh, nggak ada batch 81.
Ada itu batch 81 di ruangan 5.
Enggak di
Batch 81 di ruangan 5 dia.
habis 8 terus.
Iya, batch 81 di 5 dia. Ini kita naikin ya.
Oh itu 0059 ya.
Ini supaya kita nggak turun dari itu. Oh, 81 udah ada nih. Itu dari itu ya.
Itu kalau aku tuliskan nomor 59.
Iya, di ruangan 9 bagus.
Oh.
Seminar ruangan 3 di hari Jumat. Iya, makanya. Istirahat cuma setengah hari. Siang. Siang. Bisa lah di luar sampai sidang, siap gitu ya. Cuman Irsyad yang di hari Minggu kayaknya. Masih nggak ya? Saya masih makan malam ya. Betul. Oke, kita panggil Mas. Katanya nih jam 3 sama 8. Jadi siapa udah bilang jadinya dari dulu terus siapa yang tadi? Mas yang tadi di sini ya? Mas Romi sama Okay, ready to the next match? Okay, maybe just get your seat please for team 84 here and team 3 left side. Sama-sama winner nih ya. Alright, please choose number 2. Numbers. Okay, number. So you decide will be the first or okay, will be the first. And for that, I would like to reminder, actually during the debate session, please do not interrupt your opponent when they are maybe give comments or give question, and then we are answer your question. Okay, just waiting for them finish their statement, and then after that you can respond. Okay, maybe we can start. This is your PPT. Okay, please set the timer for 3 minutes. Okay, 3 minutes you can present right now.
Okay, hello everyone. Let us present our study. Next. Okay, imagine this is Andy. He just enrolled in a university in Banten. He was born with HIV, but his peers doesn't know it yet. At the stage where the peer acceptance really matter for him, he think a lot about what do their peer know about HIV, how they feel about people like him, and how they get trusted information about that. Next. Banten carries 76% of Indonesian HIV burden alongside 11 provinces. So we concern what do first-year non-health track student in Banten already know, believe, and where do they get HIV information from. This is a baseline study before any campus exposure shape them. Next. This study design is cross-sectional survey from Hafiz 2020 with 134 first-year student age 17 around 20. We do data collection about information, search, HIV knowledge, and attitude, and then we do statistical analysis. And the study outcome, the study identify knowledge and attitude gap to inform the need assessment to Satgas PPKS to handling sexual violence and education.
Okay, next. So this is our result. Again, as the sample size is small and this comes from one university, the scope of this study is only within this university itself. And we see that these students, they generally trust healthcare worker the most, but only 6.7% turn to internet for turn to healthcare worker for their primary source of information. Meanwhile, they use internet the most, but only 6.7% claim that it is the most trusted source. So we see this this paradox, which can inform like further down the line the intervention design for these students. Next. So we see that generally their knowledge and attitude scores are good, with a significant moderate positive correlation, as we can see in the Spearman's row analysis with the row of 0.35. But when we look at the attitude subdomains, we can see that the descriptive data is that stigma scores the lowest among the other attitude subdomains. So they generally show positive attitude, but stigma, they're still showing stigmatizing attitude toward people living with HIV/AIDS. Next. So again, this study is a baseline study. We can use these findings to prioritize needs assessment before designing any HIV-related education program. And the next step is to do a confirmatory study with a total sampling, a validated instrument, and a confounder measurement that will build the evidence base for Satgas PPKS program design in the future, so that students like Andy can feel accepted and supported. Thank you.
Okay, thank you for your presentation from Team 3, and set the timer for 6 minutes for debate session. Are you ready? Ready?
Yes.
Okay.
Okay, so you mentioned that the study is based on Hafiz 2020. Is that correct? Yes, but yes, I really read. I just like Googled some of the your exact titles on the internet, and I found that there are so many titles that are similar to this study. What novelty do you bring to the study?
Yeah, all right, so we're not claiming novelty in this study. What we contribute is the gap that that study has been conducted everywhere, elsewhere, right? But such information does not exist to support institutional programming in this particular university. That's the gap that we want to fill. We're not claiming novelty.
Oh, okay. If you're not claiming novelty, so that why don't you just use the past data to directly apply to the university without making new study? So which is more, I think, more efficient to do.
Yeah, absolutely. So the other studies are actually the findings on this particular field is very variative. So this is a very old public health knowledge framework, but these days it's actually being challenged a lot, and so we don't want to use like widely used knowledge generation. Yeah, but to one very specific population, we want to make sure it's supported by good evidence.
Okay. You mentioned in the conclusion that the understanding of the RT therapy is really should be increased, but we found that in your result that the highest knowledge that get is from the treatment knowledge part. It's already is of 85% if I didn't mistake. So why you still stated in the conclusion since the participants already high knowledge about the ART treatment?
So we believe that general knowledge, the study itself supports general knowledge is good, but when we do like a subdomain analysis and item analysis, we can see like where the weakest links are, and we based on those data, which we don't have sufficient space to present in the poster, we believe that those are essential to be addressed as well.
So you mean that the patient, the participants, not health care participants should know the dose of the treatment?
So it's not about the particular question. Actually, the particular line is saying that not every HIV patient should receive ART treatment, which is wrong. Every patient should have that, and they do not know that. So we think that is one intervention point that also needs to be mentioned when we design like knowledge, education program.
Yeah, but you mentioned before they should know about the dose treatment also. That's why I would like to confirm. So the next question is I just wonder why you use this 134 participant. Is it represent all the study, because you didn't mention all the population and you justified only the sampling is 134 and is it represented to all the population. Also, you just also mentioned that is the female is dominant in this participant. This is
because our study is cross-sectional study, so we involve all the participant at one time. So during the data collection, so all the participant is 134. So we get all of information from them.
Yeah, so the study is actually using conventional sampling. So we acknowledge the sampling bias and the sampling limitation. And that's why we are not claiming any generalizability. This study only, scope is only to inform future studies, more robust studies, as we already mentioned, confirmatory studies with larger population size, preferably total sampling, and with more validated questionnaire and a more robust design. Yeah. So that's the next step before like informing the program decision itself.
And then for the I concern with also the ethical issue, and you ask the informed consent for innovation, because this is the first year student and they still a vulnerable respondent because they're under 18. So this is already got the informed consent from the parents of the patient.
Yeah, we collected informed consent from the students themselves because generally within the medical setting, like the definition of children varies a lot. Sometimes they use the cutoff of 17, sometimes they use until 15 for children, right? So we took that 17 is not considered children.
No, because but based on the law, the under 18 is still need consideration for the parents. And I don't know how you get the ethical clearance if your respondent is the vulnerable respondent.
Yeah, well, maybe that's because of like the different ethical regulations, but where our studies conducted, it was permitted to to do so, the informed consent for this particular population. But for future reference, then that should be, one thing of our caution is that to be more careful with the informed consent to for under 18 to use parents instead of self-reported informed consent.
That's it? Yeah, okay. Time's up for the first round. And just set a timer for 1 minute for the time to break. And set the 3-minute slide for team 84. Is the correct one? Slide? Yes. Okay, go back to master slide. Just wait for 30 seconds again. Okay, set the timer for 3 minutes and also the 3-minute slide. Okay, and then are you ready? You can start right now.
Good morning, ladies and gentlemen. My name is Haryanto. I'm a college from Today we present the emergence of colistin-resistant and hetero-resistant in Acinetobacter baumannii by a sequential time kill and molecular characterization study. Next slide. So colistin and polymyxin B are the polymyxin class of antibiotic with mechanism is binding to lipid A of lipopolysaccharide and causing cell lysis of bacteria. This antibiotic used as a last resort drug to overcome infection caused by multi-drug resistant gram-negative bacteria. Since 2000s, the first clinical isolate of colistin-resistant A. baumannii was reported, and it will happen if it will happen the era before the antibiotic was founded. Thank you. Next. So the objective of our study is to evaluate the bactericidal activity of colistin and polymyxin B and their roles in the emergence of resistance, including heteroresistance and adaptive resistance, and to characterize genetic alteration associated with this antibiotic resistance. We use clinical isolates from the patient that has colistin treatment 8 days before and after the treatment, the susceptible one and the resistant one. And then we do the DNA sequencing to determine the difference, and then we perform the sequential time kill. Next. And we found that there is a mutation in PRMB gene in the resistant strain, showing the resistance is facilitated by the LPS modification. Next. And we found that in the first time kill curve until second time kill curve that the susceptible one, called S, could develop to step-by-step resistance under colistin pressure, but not in polymyxin B. And called R could grow until 16 times MIC, showing the high level resistance, but has low adaptation in polymyxin B. And we found there is an overexpression in LPXC in this strain. And then we found that there is a subpopulation from the resistant strain from the beginning before their contact with antibiotic, and this subpopulation showing the LPS modification, not only showing the LPS modification, but saw only loss of LPS by LPXA and LPXC overexpression that mentioned in the reference before, and this mechanism showing the high level resistance compared to the other strain. Next. So, A. baumannii adapts rapidly under colistin selective pressure, but minimal adaptation to polymyxin B based on these clinical isolates. And this mechanism of resistance is a dual-step process from the LPS modification towards the loss of LPS and leads to the high polymyxin resistance. So, what the implication of the study? The sequential time kill over a simple approach to discriminate different pedimodal structure and could describe the emergence of resistance. And based on this PD model, we could predict and prevent the resistance in the future. Thank you so much.
Ready? Okay, and then you can start now.
So you're using a Sanger sequencing, right? That's like on selected loci, as far as I understand. Did you do like whole genome sequencing on like different isolates to confirm that the strains are identical like elsewhere?
Thank you for the question. So this is the clinical isolates, and this is the bacteria that we isolate from the patient has got colistin resistance, and then the colistin resistance mechanisms from whole genome sequencing is already established. And but why we concern on the Sanger sequencing concern to the specific genes, because we already know that the mechanism of the colistin mechanism resistance is only specific to this gene, PMRAB, and LPXAC. So that's why we focus only these genes, because whole genome sequencing, the whole mechanism resistance of the acinotobermin is already established, and only this mechanism to found.
And then why was the polymyxin B is not included as a primary comparator? Because in a clinical setting rather than, why not?
Yeah. Polymyxin B is not used as they not used as the clinical guidance in multi-drug resistant cases. Only colistins. But in vitro study we could use it because it's not in vivo study. So we yeah, but I think you mistake the slide. We used polymyxin B as a compare study in vitro. Yes, that's why we found that polymyxin B has low adaptation compared to colistin. That's why we this is a new perspective of the antibiotic polymyxin class in the future.
And then how you pull out the possibility that the resistance result is not from spontaneous mutation rather than antibiotic selection?
The spontaneous mutation is...
Yeah, how you select that bias?
We not... this is a clinical isolate, as I mentioned before. So the isolate that we use is from the same patient before and after the colistin treatment. So we didn't predict the, we don't want to predict the mechanism or best spontaneous mechanisms, because we would like to know the difference only how this resistance mechanism could happen in the patient. And we found that compared to the sensitive strain, there's a PMRB mutation. This is only the determining study.
Yeah, because then your conclusion actually endorsed like PMB over colistin clinically, and it's usually a long step until you can say that. So yeah, like what's your basis actually for recommending this when the next step wasn't done?
No, we're not recommending clinically PMRB in this our conclusion. We only say that in vitro study, based in this in vitro study, PMRB has the bacteria has low adaptation in PMRB. Yeah. Yeah. So this is not, but the message of this study is time kill. You should consider the main message that time kill experiment could develop a PD model, and this PD model could predict the dose that we will use to the patient to prevent the resistance happen to the patient.
And then do you expect that the same resistant mechanism occur in other multi-drug resistant on this isolate with different genetic variation?
Excuse me?
The you know, right, the patient has a different background, genetic background variation. How do you expect?
Oh no, this bacteria itself is not related with the gene variation of the patient, because the gene variation, the mutation in the bacteria is happen because they challenge to the antibiotic. There's
okay. I'd like to add something to the clinical setting, because it needs to be clear that actually we actually not recommend. We didn't say we recommend polymyxin B, but polymyxin B actually has the lower the bacteria has lower resistance to polymyxin B. So that's why if someday clinician wants to use a kind of polymyxin B as a last resort for extended drug-resistant bacteria, they could potentially consider polymyxin B than colistin.
Then what would this study like inform for like future studies to be able to change the actual policy to use polymyxin B instead of colistin?
Yeah, it's actually this study impact to our country because after I published the meta-analysis of the study of colistin, clinician from Dr. Sutomo contact us, and because they found the multi-drug resistant cases in from the patient with already cannot cure by the meropenem, and then they ask us about how they can use colistin to this patient, and I give them the consortium recommendation of the colistin, how to use it, the dose that considerably safe for, to the patient, because this colistin is really nephrotoxicity. That's why it's used as a last resort drug and cannot use as a standard guideline.
To add, actually, if we as Indonesia want to use the medicine, colistin is not readily available in Indonesia, so we need to order it abroad. In order to order it abroad, we need a special recommendation from BPOM, this is called AUA, and from Mr. Haris consult from, in Sutomo, they already got the EUA for use for extended drug resistance, so we are covered in that.
And they should import it from Singapore.
Okay, time's up. Okay, that's finished the match for this match. Maybe just wait for 5 seconds. Okay, so we have the final score here. So the winner for this match is team 84 with the score 18, and the score for team 3 is 15. Congratulations for both of you. Please 1 minute.
Aduh, susah banget. Sering banget studinya. Iya. Kayak dengar studi bagus tuh kayak wah. Sampai udah kerja sama.
Yeah, congratulations to both teams. Just to encourage everybody, there is no winner or loser actually. As long as your work can contribute to the society, that'll be good. But consider it as exercise to take a look. There's no perfect research, there's no perfect data. So hopefully this skill that you guys learned during these few days can actually give positive impact in your endeavor in the future. Good job. Thank you.
Okay, thank you so much for the feedback from Mr. After this, you have just 10 minutes to break, and then you can match to the Semeru 2. Semeru 1, sorry. Semeru 1. You will match?
Yeah, but what's the time for the next match?
10 minutes after this. Yeah, because they just finish right now.
Can we ask for 15 minutes or 10? Yeah, they need to learn more faster.
Okay. Yes, go please. 10 minutes ya. Because in Ramadan we stay 10 minutes. Okay, jadi pas
Oh, pemenangnya 82. Yang 8. Ini 15. Oh, cari orangnya ya.
Terus nanti 95 lawan 84 ya di sana ya? Di sana 95 belum tulis deh nih dengan dan 83 aku lihat aja deh.
Oh iya.
Terus kita di sini nomor 4. Ya, match terakhir di ruangan ini. Kita istirahat 10 menit dulu karena mereka baru selesai match di ruangan sebelah. Ya, 10 menit lagi Pak Ahmad. Nanti aku cari Pak Ahmad di sana lagi.
Boleh. Terus sebelum itu saya udah balik gitu.
Oke, siap Pak Ahmad.
Kakak tim berapa? Aku 83.
Yang ini?
Enggak, seluruhnya.
Seluruhnya?
Iya, kakak.
Bukunya tim 83.
Aku tim 83.
Bentar, aku coba lihat dulu.
83 itu
Mana 83? Oh, yang di sana.
yang satu slide doang.
Yang satu slide doang. Oh, aku tahu. Ya, aku juga dukung gitu.
Nomor 4 lagi ready di samping. Dia
Tapi?
mau pindah ke sini.
Oh.
Yang 59 itu siapa ya?
59 itu kayaknya ruangan sih.
59 itu dari 8. Dari Bromo 5, aku udah dari tadi.
Match 83 tapi nggak ada main di sini nih. Yang siapa namanya tim 83?
Dia langsung sakit Cina kalau menang ya.
00 yang 0084.
Enggak 83.
0083.
Oh 83 lagi match dia di sana
Iya,
nih di Jani 1.
Iya.
Nah, coba lihat nih.
Ikut.
Kita tunggu.
satu lagi.
Ngawur ya? Coba kayak nggak pelajar berarti. Jadi dia dari mana ya bisa sampai sholat pagi?
Ini yang warnanya keluar, warnanya punya dua. Yang ada gemuk.
Oh, I see.
Itu yang menang di sini tadi. Yang Tiongkok. Oh, dia mau tanding di ruanganmu?
Iya, tapi kayak kita belum ketemu. Belum ada di sini. Tim berapa, Mas? Ruangan 6 tadi ya dari ruanganmu?
Itu yang mas
84 tadi, 84.
Dia pemenangnya kan?
Iya benar.
Dia lagi keluar tadi.
Kita 59, 59 tuh tim yang mana? 59. Iya 59 tuh tim yang mana tadi dari ruangan Mbak Adinara?
Oh, yang gue tadi Padinham.
Padinham itu tim berapa?
119 ruangan gue ini.
Kalah dia? Kalah dia?
Kalah sama 00.
Enggak, Kak, ruangan kalian tuh bukan yang D001. Iya kan, kalian udah D004 sama 59 tuh nggak di ruangan 2.
Ya, di ruangan 2 sekarang.
04, iya, yang dari ruangan 2.
Iya, betul. Jadi nggak ngerti juga. Gitu dia bilang. Nggak yakin. Nggak apa nanti aku yang tunjukin. Aku nggak aman. Kan lo aja. Saya cari orang yuk. Ayo cari orang yuk, cari orang.
Yang 04 aman, dia duduk di depan.
Dimana?
Yang 59 yang pemadam. Ruangan seberang. Cewek dua. Iya, di 59 doang. Lawannya. Oh, jadi ke sini. Siapa? Ngapain dia di situ? Kan saya suruh tandingnya di sini. Kenapa dia ke sini?
Maksudnya diajak.
Saya nggak tahu. Dirimu yang 059?
Enggak.
Oh, lah kenapa nggak dibawa ke sini?
tim 4. Oh, ini berarti 59. Oke. Okay, both of you ready? Maybe you can get a seat first for team 95 here and 84 here. Come on, come on, come on, come on. Have here, please. Sorry, 59 and 4, yeah? Salah. Yeah, 59 and 4. Room sebelah. 59. Yeah. 14-4, you can sit here, and 14-59, left side. Okay, maybe you can choose head or tail. Yes, choose the queen, head, your tail. Okay. Yes. Who will be the first? Head or tail?
They present first.
They first. Okay. So please prepare for team 59. And also I would like to remind you in this match we have 2 rounds, and the first round you will be team defender and you will be team attacker. And during the 3 minutes you can present, and after that 6 minutes there are debate session. In debate session you have 30 seconds for team attacker to attack them, and 1 minute to give your defend your idea. And during the debate session, please do not interrupt your opponent. Just wait till them finish their statement, and until that you can respond. Okay. It's clear? Yeah. And after that, 1 minute to break, and we can move to the next round. Okay. Please set the 3 minutes for team 59.
Yes, that's correct.
Are you ready?
Check. Okay, ready.
And then you can start right now.
Okay, thank you. Good morning, everyone. My name is Denny, and my partner Felicia will present our study about optimizing community tuberculosis screening in Yogyakarta. Next, as we know, Indonesia is the country with high TB burden, which ranks second globally. One approach is community active case finding using portable X-ray with AI, but this tool lacks sensitivity and specificity for effective screening, and maybe contributing to both misdiagnosis and unnecessary diagnostic testing. To address this, we aim to improve the clinical scoring algorithm to improve the TB screening in community. Next, the method, we using the data of participant active case finding by Zero TB project in Yogyakarta, and we using the regression logistic to clinical predictor and AI X-ray score, and then convert B coefficient into the scoring system to validate the diagnosis accuracy using tenfold cross validation. So the result is next, please. This is the predictor factor that we get. We have 7 predictors selected, and we validation with tenfold validation. Then we got the high AUC 0.97. That this is valid and good to build the predictor. Then next. Table 2 is our scoring, and we choose the optimal threshold is above or equal of 11 that have the high sensitivity and specificity get over 93%. And when we use the scoring system, just focus in 1.1 and 2, from the baseline, the total of experters before we using scoring, we need 94,000 testing of expert. Then when we use the scoring, we just 5,000 of tests with the yield is higher. Then next, this study is we study can translate a complex multivariate regression model into field level and easy to use and research efficient trace tool. And this is recommend to screening protocol modification to prioritize high risk individual to screen and reduce field logistic and cost issue. Okay, thank you.
Okay, thank you for the presentation for team 59, and also please set the timer for 6 minutes for your session. Set, but if you're ready, yeah, and then you can start right now.
Okay, so you use GenExpert, but GenExpert has low sensitivity, around 40 or 60% to subclinical TB, especially paucibacillar case, which is also subclinical TB. This is very good confirming TB, but it misses many true subclinical TB when the result is, why wasn't you choose more sensitive reference standards such as expert ultraculture, for example?
Ultra is actually the cartridge, so we use GenExpert Ultra in this study, and it has been done a couple months before. And it's true, if we use the previous expert cartridge type, it has lower sensitivity for subclinical and paucibacillar study. So we use the newest Ultra cartridge, the one that you mentioned.
So also for subclinical TB, it's generally defined as microbiologically active TB in the absence of symptoms. However, model use cough over 2 weeks and unexplained weight loss as predictor. This is not conceptually fit between outcome definition and predictive variable, and your predictive variable.
Yeah, we got your point. So that's why in our scoring system, we don't only use symptom screening only, but we also use the chest X-ray using the AI assisted. That's why we still can catch the participants with asymptomatic TB that has no symptoms, like you said, cough or unexplained weight loss.
Yeah, so but the CXR AI score is also problematic because the performance of GXR AI score alone and in comparison with the full model is not provided here. So what additional predictive value was gained by adding clinical risk factor here?
Okay, if we talk about the context of public health, in my table in result, actually there is the result of GXR only, and with compared to our scoring system, and actually there is the 4 cases different if use X-ray, just X-ray and combine symptom and X-ray. But in the practically to found 4 cases is still needed to do because masih dalam budget apa ya, masih
we still have the program has the budget to do that. Do you still have time? I also want to add, as what you asked in the previous question, we don't want to miss the symptomatic patients too, and we have other reasons, but we don't have time to explain.
Okay, based on your by clinical usefulness cannot be judged solely by discrimination metric as it show using the AUC sensitivity specificity. It cannot solely judged by the discrimination metric decision curve analysis or net benefit evaluation should strengthen to be claimed that the proposed algorithm can improve clinical decision making. You get it? So
I think what I understand is that you're asking about our AUC. Yeah, in our new scoring system, we have the AUC of 0.97, which is very high, and that shows that our study is valid, that our scoring system is really good.
Okay. The model, the AUC is high, but however, the calibration performance was not presented. Without calibration, assessment it only predicted risk accurately or not. Calibration itself.
You mean calibrating our scoring system? Yes. Calibration of our scoring system, we use the tenfold cross-validation study. That's the calibration step.
Okay. Yeah, since you mentioned about cross-validation, I don't think your study have an external validation because tenfold cross-validation, I think it is internal validation. So you can't be sure that the model will have the same performance to the different population or different health facility or different radiology technology. Okay, so because you have no external validation in here.
Yeah, but the tenfold cross-validation, the process itself, it helps us to still use 100% of our data without dividing the data into two parts. But actually, we also did the 50% split. So 50% for the internal, 50% for the external, and we still got an AUC of 0.79 something. It's still very high.
Still 0.9, but just a little bit different.
Is there that? Okay. Actually, your design is cross-sectional retrospective, but your conclusion is to accelerate diagnosis, right? This is to improvement in diagnostic timelines were not directly measured on your study. So the conclusion appear inferential rather than the evidence-based of diagnostic.
Sorry, can you repeat the point?
Yes, this is a cross-sectional retrospective study.
Yes,
and
but,
1 minute to.
But the conclusion, you want to accelerate the diagnosis, right?
Yeah.
Okay. So the improvement in the improvement in diagnostic timelines were not directly measured. Yeah, because because you state that your study can useful for accelerate the diagnostic by what?
Okay. Because our aim is the background I told that there is many scaring methods, right? Symptom, X-ray, and sometimes it's like for the sensitivity. But and we want to how to address this with we prioritize the screening, and this is can address the logistic issue, but not about the accurate diagnosis, but to prioritize the people who screen.
I also want to add, in our terms in the public health for TB, accelerating the diagnosis finding means finding more people with TB, and that's what we do in our study. Our study shows how to do exactly that.
That's it? Okay, time's up for the first round. And you can see on the screen. For team 4, you have score 9, and for team 59, you have score 11. Just 1 minute to take a break.
Yes.
Go back to the first slide, and then are you ready?
Yes.
Set a timer for 3 minutes. You can start right now.
Okay, so maternal undernutrition remains a major challenge in low and middle income countries. It contributes to poor fetal growth and adverse birth outcomes. To address this, the World Health Organization recommends balanced energy protein or BEP supplementation for undernourished pregnant women. While previous study has shown that BEP supplementation improve maternal and also neonatal birth outcomes, however, there is one important question remain unclear. That is, does timing of supplementation influence infant anthropometric outcomes? Next, to answer this question, we conducted systematic review and meta-analysis of randomized controlled trials evaluating BEP supplementation during preconception, pregnancy, and postpartum period. We searched PubMed, Scopus, and Cochrane database through December 2024. Next, 29 articles from 21 RCT conducted in low-middle income countries were included in our study. The studies were grouped according when supplementation was initiated. It is before preconception, during early pregnancy, during late pregnancy, or during postpartum period. Next. So overall BEP supplementation improve infant anthropometric, but the magnitude of the benefits is different according to the timing. For birth length, the supplementation initiated at preconception resulting in greater improvement than supplementation in third trimester. For length for SZ score, both preconception and second trimester produce greater improvement than postnatal supplementation. And for birth weight, larger effects were observed among studies initiating supplementation during third trimester. Next. So our research suggests that different anthropometric outcomes respond to different window period of giving nutritional intervention. Earlier supplement appears more beneficial for length and length for SZ score, whereas later supplementation may have greater influence on birth weight. In conclusion, our review highlights the question is not only whether BEP supplementation work, but also when it should be provided. And understanding the timing of supplementation may help improve future maternal nutrition program and maximize the benefit for the outcome of the infants. Okay, thank you.
Okay, thank you for the presentation from team 4. And please set a timer for 6 minutes.
Okay.
Are you ready?
Okay, thank you.
Okay, ready. Once more, ready?
Ready.
You can start right now.
Okay, this is interest study actually, but recaps on your finding on the preconception woman. Did any of the study you review address compliance and operational feasibility women in low middle setting? Just wondering how we could practically target women on conception in LMIC setting, considering the economic perhaps. Okay, you can.
Yeah, from our study that we were included in our study, all of the study, many of them also measure the compliance of their subjects to the BEP supplementation. And the compliance are also in a good result. So we can be sure that the result we get here, the outcomes, is influenced by the DEP supplementation because of the high compliance of their subjects.
You utilize a random effects model, which is appropriate for the LMCI setting, but you omitted the I2 statistic from your results. If your I2 is high, your mean differences in figure 3 will be meaningless because the underlying data is too scattered to pull reliably.
No. Yes, actually the I2 for from our study it's 0, so it's homogeneous. I square, you mean?
Yeah,
I square. Okay, I square, it's mean heterogeneity, right? From our study, it's
0%. So it's totally already homogeneous.
It's good if you present that too. It's a very good finding, right? And also, in your implications, you recommend that global nutrition program should shift from the current antenatal care into preconception, and that will be very costly especially in the resource allocation. But I want to highlight that the foundation for your statement is only from very little data, the preconception data based on 3 studies, birth weight, 3 for birth weight study, 3 for birth length, and 2 for LAZ. I think that's not enough to make the
Yeah, just want to make it clear that actually we do not interpret the finding as the proof that the timing alone explain the differences of the outcomes. Our review identifies timing as a potential effect modifier that may contribute to variation in infant growth, anthropometric outcomes. So it may result in hypothesis, and this hypothesis is used as the basis for the future clinical trials.
I noticed a disclaimer at the bottom of the poster stating that maps and graphs are made by AI. Systematic reviews require exact visual representation of statistical output. How did you validate that? The AI did not misrepresent the scaling of your confidence intervals and mean difference in figure 3.
Okay, thank you for actually for the calculation of the mean difference, it's using review manager. So for we are using the AI. It's for the mapping only. It's for the visualize. So actually the number is from the calculated using review manager. Review manager is for the meta-analysis.
Okay, it's about figure 3. I noticed your figure in the preconception estimates rely on only 2 to 3 studies, significantly fewer than trimester 2, right? Yeah, with such a limited number of study, how you confident about your statistic robustness? Because the study is lower than.
Yeah. Yeah. This is actually this is a valid point. The evidence base for postnatal BIP supplementation is indeed much smaller than that for prenatal supplementation. But our finding regarding postnatal supplementation should be interpreted with caution. However, this imbalance itself is an important message that it highlights the major gap in the literature. As most BEP research has focused on pregnancy, while relatively few studies have evaluated supplementation beyond delivery. But despite the small number of studies, we observe a consistent pattern in which prenatal supplementation show greater benefit for length for AZ score than postnatal supplementation alone. Nevertheless, additional well-designed postpartum trial are needed to confirm this finding. Yeah.
Your meta-analysis compares LAZ across different intervention timings. However, LAZ is a dynamic metric dependent on the age of the child at follow-up because there are confounding factors such as breastfeeding quality, childhood infection, etc. Since you didn't specify the measurement timeline, how did you control for the age of the infants across these 11 studies?
Actually, we have put the measurement timeline for the prenatal studies. The timeline is at birth. Okay, for the postnatal study, we put the timeline as 6 months of age of the baby age. Yeah.
So different timeline for each study.
Yes,
I think you
but
cannot include that.
but the length for Z-score is a standardized Z-score, so it should be compared because it's compared length of the baby based on his age. Right.
That's it. Time's up. Okay, just waiting for maybe. Okay. So that is the final score for this match, and congratulations for team 50. be the winner for this match with the score 20. And for team 4, you have score, congratulations, and you have score 19. So in this match, the winner is team 59. Okay, maybe 1 minute for judges feedback.
Okay. Okay, thank you. So I just have one comment. So actually in science there's no right or wrong. It's only about presenting the strongest evidence, and we evaluating with the different perspective, of course, supported with the data. And both team already show that, so congratulations, and good luck for the next step.
Thank you. I think this could be one of the good examples how both teams can actually argue cordially with good courtesy, friendliness, but yet still very sharp in presenting the arguments. I think this could be one of a good example. And also I noticed both works actually will be applied for policy making. Will be what do you call this, implemented in real world. The only thing I'm probably missing is that what would be the next step, because of course I guess I want to ask actually now from the team, the TB team. So what do you think will be the next? I don't know. Whether you need future research, is it something like prospective tests to really implement it? Or something before, because I don't think we can actually directly apply it, right? Okay, and same question with this MMC supplementation. What kind of works, future works that you really need to really close the gap before you actually implement it? If you don't mind, just maybe a short answer. Yes, go with your first. You need the mic? Yeah.
There are two steps that we want to, the first is we want to evaluate the cost effectiveness using our scoring system. Does it really save that much money? And then we also want to implement it in settings with different prevalence, because the prevalence in Yogyakarta is lower than those in other cities in Indonesia. And also we just get the insight from the senseis here about the use of machine learning to have a even better prediction.
Oh, I see. Okay, thank you. For the other team?
So for us, actually, yeah, like the other team said that the number of study in our postnatal group is quite small number. So this not giving the causality conclusion in our study. So we need some more clinical trial, especially in postnatal studies. And our study acts as a hypothesis for another future studies, I think.
Oh, okay. All right. Thank you. Thank you. Good job, everybody. Very good.
For the match, the grand final.
How many more matches are there then?
Yes.
How many more matches are there?
4.
4, yeah.
Yes.
So what I was mentioning actually previously, that this match was actually not supposed to go forward. That's what I was mentioning in the other room.
Yeah.
That all the future matches were supposed to occur there. So that's what I was mentioning. This match actually was not supposed. That's why I was telling you before. Yeah, but anyway, so it's good you did it. So congratulations. Yeah, that's what I was saying. I was over. You guys remember that? I was telling you over there that actually your match won't go forth. It'll be in the main room. Yeah. So anyway, okay, great. So get ready for your next one. Okay. Get ready